One. Good morning. This is Dr. John Bennett broadcasting from Bharatnagar, Nepal. Today we have the first of the talks of the All About Spine series directed by Nicholas Peeth. And today we have the honor of having Salman Sharif, a frequent hangouter and the organizer of a conference where I got a lot of the speakers from today. But before we turn it over to Salman, let's introduce the guests. Hello, Bernardo.
Hello, my name is Bernardo de Andrada. I'm neurosurgeon and spine surgeon from Rio de Janeiro, Brazil, and I'm on Arizona doing my research fellowship. So I'm very glad to be here with you and watch the lecture of Dr. Salman.
Yeah, welcome, Bernardo. I'm sure Salman's heard of Barrows Neurosurgical Institute in Arizona. That's where Bernardo is.
Yeah, that's where I was trained as well.
Very good. Okay, and Marco, could you please introduce yourself?
Yes. Hi, my name is Marco Antonio. I'm from Bolivia. Thank you for the invitation.
Okay, welcome, Marco, a frequent visitor. Okay, Salman, welcome, and it's all yours.
All right. Thank you, John. There we go. Is that okay, John? Is that working?
Yes, it's perfect.
Okay. Today, I think what we're going to do is we'll be talking about spinal metastasis, prognostic scores, and when to operate on these patients. So it's wonderful to be back again. This is a study. This is a couple of studies that we've recently done in our institution, and that's close to my heart. The reason being, many a times surgeons were making decisions on their own, not knowing which patients to operate and which not to operate. But to make it uniform, I think all these prognostic scores have come in and have played a significant role. This is actually Pakistan. What we are seeing here is Ferry Meadows. This is a picture from there. So these are some of the horses along the valley, which is close to the K2 and the Karakoram range of mountains, which are one of the highest, just like where John is at the moment in Bharatnagar. So in Nepal, they have the highest mountain in the world, but out of the top 10 mountains, 6 are in Pakistan in this range. Let's talk about metastasis. So bone is the third most frequent metastatic site of distant spread of carcinoma. Classic primary sites are breast, lungs, prostate, kidneys, and thyroid. The vertebral column is the most common site of skeletal metastasis. 10% of patients with metastatic disease will develop spinal mets, and of those, 1/3 will become symptomatic. 2.5% of these will develop cord compression, and dorsal spine is the most common site, followed by lumbar and followed by cervical. The causes of neurological deficits are mechanical, vascular, and instability. Mechanical, when there is direct compression of the tumor, compression due to vertebral body collapse, and vascular, when there is ischemia to arterial embolism and venous congestion. Instability, when there is kyphotic deformity or spinal malalignment. Do you guys have a phone? Workup includes nice and evidence. Can you hear me?
Sorry, your slides is not working, I think.
Let me see.
Yeah, I'm sorry, it's not moving. Thank you, Marco.
Yes.
There you go. That moved. Yeah, that's moved. Okay.
Okay. Yes.
Shall I go back again? Is that okay?
Decision making tough. That's where the slides are now.
What about now?
Yes. Decision making tough.
No. Did you guys get the neurological deficits?
No.
Can you see this now?
We can see decision making tough.
Okay. What about now?
Causes of neurological deficit.
So maybe I stick to this because what's happening is when I'm using the slide share, it's not working.
Okay.
So let me use this then.
Okay.
So just going to go up and where slides were not moving. I'm going to start maybe from here. That 2.5% will develop cord compression, and dorsal spine most common affected site. Causes of neurological deficits are mechanical, vascular, and instability. Mechanical includes direct compression because of tumor, compression due to vertebral body collapse, vascular incompetence due to ischemia, due to arterial embolism, venous congestion, instability, and which includes kyphotic deformity and spinal malalignment. Workup, obviously, according to the NICE and the evidence-based guidelines, includes spinal metastasis produced by the Dutch National Working Group on Neuro-Oncology, CT, MRI, and PET scan. Obviously, CT would include CT chest, CT abdomen with contrast, and MRI of that particular region and nearly of the whole region to make sure that there is nothing that you miss. PET, wherever possible, does help in deciding what exactly needs doing. Obviously, decision making is tough. Why? Because there's urgency to prevent paralysis. There is potential of post-surgical morbidity in weak patients with limited life expectancy. And in these patients, on one side, we have got urgency. On the other side, we don't want to be causing problems to them. We're in very weak and frail patients. So there is a dilemma. The dilemma is about this decision making. There could be tumor load, life expectancy, exact pathology, functional status, age, comorbidities, neurology, bone quality, instability, progression of disease, and treatment options. So all these factors play a role in for us to decide what exactly we're going to do. Obviously, wishes of the patient are very important, and tumor load and life expectancy could be one of the major factors that would play a role. So on one side, you could have a patient who could be alive and well, and on the other side, you can make the same patient alive and miserable. So if you've got somebody who's got less than 6 months survival, many people will consider no surgery unless you want to do surgery to improve their pain or misery. So the prognostic factors overall would depend on functional status, number of visceral metastases, primary tumor pathology, and age. These were the factors that when we looked at, found them to be the most significant. So the scoring systems, the various scoring systems which are available, and I'll just briefly go through them. Tomita basically has 3 factors: primary tumor, visceral, and bone metastasis. Tokohashi had 6 parameters, and I will show that later on. NORF gave us a classification system which found non-breast metastasis, recurrence, multi-level surgery, and paraplegia. So non-breast metastasis, recurrence, multi-level disease, and paraplegia to be the most significant prognostic factor. Modified Bohr is a very simple scoring system, which you will see later on is very effective and routinely used nowadays.
This is mobile.
Here. Palliative goals of surgery. So depending on the primary tumor, obviously cure or no cure will depend on what we are doing. So, I'm sorry, somebody's got their mic on. Can you switch off the mic, please? Thank you. So neurological function, depending on if we're going to give X-ray treatment or surgery. Spinal instability, are we going to instrument that patient? Pain control and local tumor control. If you want to do a local tumor control, you can think about external beam and stereotactic radiosurgery. So options for therapy obviously is a multidisciplinary approach. It has systemic therapy, radiation, and surgery. Systemic would include chemo, immuno, hormonal therapy, and targeted therapy. Radiation would include external beam, image-guided, including hypofractionated, single fraction, and brachytherapy. Surgery includes percutaneous augmentation, open, anterior, posterior, or minimally invasive, or in-block, or intralesional. So all these could be there. So you can think about minimally invasive, you can think about kyphoplasties, you can think about percutaneous augmentations, and various approaches which are there for us to decide. And it's all a multidisciplinary approach. So why do we not routinely do a cementoplasty? And there is that risk of cement leakage in 25% of patients in some studies. And if you have that leakage, you could have cord injury, thermal injury, displaced tumors, and posterior elements are involved, tumor growth can happen. So in candidates with small numbers, include minimal collapse, no neurology, intact posterior cortex, which is very, very important, pain as severe factor, and if it's a non-junctional level. What is a junction? I will come to that shortly. So metastatic tumor outcome, how will we know what's the outcome going to be? So you have got a spine tumor study group, spine oncology study group, basically came up with this norms. Norms is neurological, oncological, mechanical, and systemic. So NOMS. Neurological is, does the patient have myelopathy, functional radiculopathy, degree of epidural spinal cord compression, tumor histology, radiation or chemosensitive or not, mechanical instability, and systemic disease or comorbidity. So all these factors will play a role in for us to decide what we're going to do with the patient. So if you've got epidural spinal cord compression scale, in which if you've got a low grade compression, then obviously your treatment options are going to be different compared to if there's a higher grade compression, so 0 to 3. So not is when there is no compression, and 3 when there is severe compression in these patients. So you've got high grade, then your decision is going to be different. And how do we know which are radiosensitive tumors? So we have got these multiple studies with us which tell us which are radiosensitive and which are radioresistant. So you can see all these tumors, lymphomas, seminomas, myelomas, breast, prostate, are all radiosensitive. Whereas if you look at this, sarcoma, melanoma, GI, lung, and renal, all of them have unfavorable prognosis. So it's important for us to know beforehand which is radiosensitive and which is resistant. Okay, so if you look at neurological and oncological assessment, so if you've got a radiosensitive tumor with low-grade epidural spinal cord compression, then you think about their external beam. If it's resistant, you think about stereotactic radiosurgery. If it's a high-grade compression, then obviously surgery may play a role, followed by radiosurgery or external beam therapy. So, you know, if we have all these together, these 4 scores will tell us what exactly we're going to do with these patients. So, if you've got a radiosensitive tumor, okay, then in those cases where we've got low-grade compression, external beam radiation may work very well. And for example, this multiple myeloma, which you see here in July of 2008 was something like that. And within 10 days, you can see that the compression is nearly gone with external beam radiation because they're very radiosensitive. So the same scenario applies again, that if you've got a low-grade compression, you've got radiosensitive radiation, high-grade, then you think about radiation or surgery. So what about radiosurgery? So there's a low quality evidence that radiosurgery should be considered over conventional fractionated therapy for the treatment of solid tumors, spine metastasis in the setting of oligometastasis disease or radio-resistant histology. Stereotactic radiosurgery is safe and effective in these patients. So for example, again, if you've got a radio-resistant tumor, then what are you going to do? Then you can think about surgery followed by radiosurgery. So basically in 2005, these guys came up with this paper and changed the way we think. So they had a prospective randomized trial and working on these patients with several malignancies causing cord compression, and the patient randomized into 2 groups, so surgery versus radiation. And you can clearly see the outcomes with surgery were very good compared to radiation. And these outcomes were not overall good for overall, but besides other things as well. So overall survival, if you look at ambulation, 84% surgery, 57% radiation alone. Duration, 122 days versus 13 days. Recovery of ambulation, 62% of patients. Recovery of ambulation, 19 in radiation. So completely different results. So actually this trial had to be stopped. And then if you look at continence, then you can see continence was intact for 155 days with surgery, 17 days with radiation. Amount of narcotic use, you can see, is completely different in these patients. Much more narcotics where radiation was involved. So survival time, 126 days versus 100 days. So this paper changed the way we think, and there was a strong recommendation that patients with high-grade spinal cord compression due to solid tumors should undergo surgery and stabilization, followed by radiotherapy. Neurological and functional outcome, pain control, complication thoroughly documented for surgery, and they showed that obviously surgery was much more beneficial. So that's when surgery came in vogue since 2005. So anybody with radio-resistant tumor, high-grade compression, surgery followed by radiosurgery. Then recently, in last few years, we've started doing something called separation surgery, where we had frail patients who could not go through complicated, long excisions of these big tumors in frail patients. In these patients, we started doing decompression surgery and separating the spinal cord from the tumor, so creating a space in between the two. That space helped us, followed by radiation, stereotactic radiosurgery. And this is close collaboration between surgeons and oncologists. And by that, we were able to, in even these frail patients, give them some kind of hope and outcome. So these slides, these pictures were given to me by a friend from Cleveland Clinic in oncology, and that's what they're routinely doing. So separation surgery, 38-year-old female with the dedifferentiated liposarcoma. And you can see what we've done is we've removed the tumor away from the cord, did not take whole of the tumor out, just quick surgery, separate the two, find a fluid space in between the two, make sure you have that intact, followed by radiosurgery, and the results were pretty good and have recently been published in many centers all over the world are doing this. So how do we look at the mechanical instability? For mechanical instability, this is independent indication for intervention. So again, the study group came up with a scoring system called SINS. SINS is Spine Instability Neoplastic Score. And when we did an integrate systemic literature review with expert opinion, it's very reliable and it can be validated. So what is SINS? So let's look what SINS is. So SINS look at location. So if it's junctional, for example, it's C2 occiput, C7 T2, T11, L1, L. So if you've got junctional, you get higher points. If it's a mobile spine, for example, C3 to C6 or L2 to L4, you get 2 points. If it's semi-rigid, for example, D3 to 10, then you get 1 point. If it's rigid, for example, sacrum, then you get no points. Pain obviously gives you 3 points. So these are the scores for looking at instability. Instability obviously can present with pain. Occasional pain, you get 1 score, pain-free 0. So bone lesions, if it's a lytic lesion, you get 2, mixed lytic and blast, you get 1. So the severe the problem, the more the score is going to be. So if you look at alignment, if there's subluxation and translation, you get 4. If it's normal, you get 0. So what we'll call body collapse, more than 50%, less than 50% scoring according to that. Posterolateral involvement of the spinal elements. So for example, bilateral elements are involved, you get 3. If it's unilateral, you get 1. So if you look at the scores, if your score were 0 to 6, then you're stable. The chances are that you do not require surgery on these patients. And this has been matched with the results that the experts had in their hands. So this is really a reliable indicator when to operate on patients. So if it's potentially unstable, then you look at other factors like age, prognosis, patient's wishes, the expertise that's available. But between 13 to 18, that's completely unstable, and you should consider surgery if patient is stable and if all those factors play a role. So since, for example, in this particular patient, you look at this, the location is mobile, and at the same time, you've got one score was intermittent. You've got a lytic lesion here. It's a mixed lesion, sorry. And then you've got alignment is intact. So all these factors, we add up this, the score is 5, and in this patient, we will not offer surgery to this patient unless there are specific reasons for it. So you've got somebody like this, who've got this subfracture subluxation with a lytic lesion, and if you add up all these scores, you get 14, which is unstable, and obviously you need to do something for it. Tomita scoring system. Tomita actually used primary tumor, visceral metastasis, and bony metastasis. So primary tumor, the good tumors, slow-growing tumors, breast and thyroid, you get 1. If rapid growth, lung and stomach, you get 4. Visceral metastasis, treatable, you get 2. Untreated, you get 4. So higher the score, the worse the prognosis. Tokuhashi came up with some other factors which are also important, which was general condition of the patient, so Karnofsky scale, which is shown here, number of other extraspinal bony metastases, number of metastases in the vertebral body, metastases in the major internal organs which are removable or non-removable, and primary site of cancer. So obviously, which was very, very important. And they said if the score was 0 to 8, then you think about conservative, whereas it was 9 to 11, you think about palliative. If it's 12 to 15, you need to think about excisional surgery. So all these are prognostic scores. I find this score to be a really reliable and simple score. And the reason being that there's nothing that you cannot get from your patient. So it's patients with no visceral metastasis, no lung cancer get 1 point, primary tumor being breast, kidney, lymphoma, and multiple myeloma, you get 1. And you get 1 solitary single metastasis, you get 1. So if the score is low, 0 to 1, then you've got average 4.8 months survival. If the score is 2, you've got 18 months survival. 3 to 4, 28 months. So if your survival is more than 6 months, then you can think about doing surgery for these patients. And this is a very simple score. So in a patient who's unfit, you can think about percutaneous fixation if they're unstable and give radiation to them at the same time. So it's intermediate SINS, so you can just do percutaneous fixation. You do not need to decompress in this patient. And then you can augment that with kyphoplasty if required in some of these unstable patients. So what assessment things that we did, we discussed this earlier, MRI of complete neural axis. We need to be sure that patient can tolerate a proposed procedure. You need to have a discussion in the multidisciplinary oncology meetings. You need to stage the tumor depending on CT, PET, labs, and you need to see if the patient's morbidity is reasonable enough for him to tolerate a procedure. So if you've got these norms, which again shows that low grade, no myelopathy, then you think about radiation. High grade myelopathy, then you need to think about doing something for them. Radiosensitive, obviously radiation. Resistant, you think about separation surgery or surgery followed by radiosurgery. Mechanically, if it's unstable, you need to operate. If systemic, able to tolerate surgery, then these patients should have surgery. Tokuhashi score, they looked at 260 patients, and what they found was factors associated with significant survival were time from cancer diagnosis to metastatic diagnosis. If it's less than 2 years, more than 2 years, or 5 years, the outcome was different, and if the age was 70 or more. So prognostic factors in symptomatic patients with normal neurology, they included pre-treatment albumin, so that's very important, along with primary cancer site, Karnofsky scale, and visceral metastasis. So we in our center did a study and we looked at what prognostic scores are important or not. And we looked at these 4 scores, which include Tomita, modified Tokuhashi, modified Bohr, and SINS. We included SINS because we wanted to see would it also tell us about the prognosis or not. And we found that Tomita have a highest statistical significance, followed by Bohr, followed by Tokuhashi. Although modified Bohr is much, much, much simpler scale to use. SINS was identified as a predictor of instability, but did not show association with survival. And then we had individual factors like age, preoperative neurology, vertebral levels involved, visceral metastasis, Karnofsky scale. They all had positive correlation with these patients. So our study had 55 patients, and then we did another study looking at patient factors and disease factors. And to see which is important. Are patients factors more important or disease factors more important in these patients? So patient factors are age, gender, preoperative neurology, pain severity, symptom duration. And disease factors are histology, number of mets, sites, extravertebral bony metastasis. And our study showed that the ultimate disease defining variable, which is the tumor histology used. That's the biggest factor in prognosis. Also, presence of visceral metastasis and levels of disease encompassed were significant predictors. Among patient factors, performance status at the time of presentation actually was the most significant correlation. Age in itself was identified as a predictor of prognosis, owing to its reflection of an individual ability to bear treatment or not. So in conclusion, we come to that now. So NORMS integrates modern radiation and surgical options, provides evidence-based guidelines for treatment of metastatic spinal tumor. SINS addresses spinal instability. Modified Bohr has a better predictability due to unanimous application of the score. Patients with spinal cord compression, secondary to solid tumor metastasis require surgical decompression. Nowadays, separation surgery followed by stereotactic radiation could provide durable tumor control without the need for extensive tumor excision. Thank you, and these are the beautiful resorts of Shangri-La in Skardu, which is in north of Pakistan. You can see all these mountains are about 4,000 meters high, and the Karakoram range behind it is 8,000 plus meters high. I take this opportunity to invite you guys to World Spine 8, which we are doing with World Spinal Society, and hopefully Neurosurgical TV Live will be there with us all along, discussing all those during this time. Thank you.
Well, very good, Salman. We'd love to televise that. And another excellent presentation. And we're honored by the presence of Dr. Kim. I think you probably know Dr. Kim, Salman.
I know Kim very well.
Hi, Salman.
Hi, Kim. How are you? How's Korea?
Yeah, he's giving the next talk.
Oh, very good.
Yeah. So basically, and then we have another panelist, Afifa. I don't know if she can identify himself or herself. At any rate, yeah, we're glad to be able to use this platform to show talks like this, hopefully to a growing community of neurosurgeons globally. And too bad you couldn't have come to Bharatnagar, Salman.
Yeah, I'm sorry I missed that. I know.
Yeah, a lot of friends. But with Dr. Kim, I don't know if you know, but Salman travels everywhere. He was posting pictures from Iceland. Man, you log on the miles in your airline account.
You don't know about Kim. Ask him what's he up to these days. He travels more than me, twice as much.
No.
How'd you like Iceland?
Iceland was wonderful. It's a different planet altogether. I think if you are an explorer, an adventurer, that's the place to be. It's like Norway.
Yeah, that's not a typical tourist spot.
Yeah, the total number of people living in Iceland is 300,000, and the number of tourists they had last year were 2 million. So you can imagine, all of a sudden the tourist industry exploded there. So there are flights coming 24 hours. All their cities are invaded by tourists at the moment.
Right, yeah, different seasons, different light.
Yep, completely different. I think food is great. Some wonderful area. You get to see lots of Asians coming there as well, besides European travelers. So it's
really
good.
Yeah, they had a chess championship there between Bobby Fischer and Boris Spassky. That's probably one of the most notable events that's occurred there in a long time.
Besides the earthquake they usually have and the lava coming down and blocking whole of the Europe. I think a few years ago, if you remember, the whole of Europe flights were cancelled because of this earthquake and this lava coming out of it. There are loads of volcanoes there.
Did you get to interact with any of the neurosurgeons there at all?
No, I know a couple of neurosurgeons from there, but no, I haven't had a chance to meet. I was there with the family, so didn't get it.
Oh, okay. Okay, so it was a vacation trip.
Yep.
Oh, very good. Okay, now we're just joined by a resident from India, Rakesh. Good day, Rakesh. Can you hear me okay?
Yeah, I can hear you. Hello, everyone. Sorry, I was a bit late. Hello, Dr. Salman Sharif. Nice to meet you. Nice to meet you once again. I had heard your one of your lecture last time. Nice that you are being a very active part of this series, and I'm very glad that I'm part of this too. And we are learning a lot through Neurosurgical TV. Thanks to Dr.
I think what John has got for you today is wonderful. The whole program and the people who have come in now and who will be participating today are all those people who are usually expert, who come to our conferences and attend and give lectures. And we will keep doing this, and John will continue to support us. We have another spine workshop coming up in December, which is minimally invasive spine. So hopefully John will be able to telecast that live for you. And then in February, we have another skull-based endoscopy workshop. And hopefully we'll have Ike and his whole gang to come along with. Hopefully we can get John over as well at the same time. to telecast as well as support all the people who are helping us in education.
Yes. Thank you. Thank you so much, Dr. Salman, and thank you so much, Dr. John.
John, you there? I think John is. Hello, John. Kim, how's life?
Yes, nowadays I'm so busy, so busy. Maybe next year, February, we will in Karachi, the endoscopic course.
Yeah. Hopefully
Yes.
we have this, but I was hoping you would be there. But I know that you're busy on that particular day because we will be missing you. But hopefully we can have you live via John. John can help you connect us during that time. Maybe you can give a lecture via live neurosurgery to our audience.
Okay, don't worry. I always keep my February for Karachi.
Definitely, no problem. February.
Okay.
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 John, you there?
Dr. John?
Okay, we are live. You want to go? If I don't know, this is your time now, or shall we? And he's put us on live on TV, and he's not there at the moment.
Dr. John, where?
Yeah. Shall I introduce you and then?
Maybe he has problem with the audio. Maybe.
Yeah, it's. Maybe I'll introduce and then you can start and John can take up from there. Shall we do that, Kim?
Yeah, we can practice.
I think that maybe I promise my time is 11 a.m. For Indian time, but not starting now.
Yes, it's 10:45 a.m. in India here.
Yes.
Yeah.
So John is back.
I think Dr. John is back.
John, you there? Kim, how's the conference?
The screenshot, yeah.
How was your conference recently?
Okay, recently in Korea we have so many conferences, especially we focus to the endoscopic spine surgery because I'm a secretary of Korean Minimal Invasive Spine Surgery and Endoscopic Spine Society secretary. I managed so many conferences, and nowadays in Korea the spine is more focused to the minimal invasive spine surgery, and yes. Spine surgery is very interesting, or many doctors, and so developed so many techniques and so many some instruments also, some developed some doctors. That's good things. Okay.
I'm sorry, it was a man-made mechanical error. Someone pulled the plug out accidentally. But sorry about that, folks. I guess you held court. Everyone held court, so I'm glad to see you guys took up the slack.
Well, the Nikolai.
Okay. The director is missing. I'll call him. Don't worry.
Well, yeah, Nikolai's giving a talk later on. So I guess we can move on to the next talk now, Dr. Kim, if you're ready.
Maybe can I start now because I still remain maybe 20 minutes.
Okay. Do you want to wait to start? That's okay. No problem.
Because I'm already announced my lecture 11 a.m. in Indian time.
Right. That's fine. That's fine. So we'll start on time for your lecture in about 20 minutes. In about let's see. 18 plus 15. Yeah, at 11 o'clock India time, right?
Okay.
Yeah.
Yes.
Yeah. We'll schedule it. We'll edit all this out when we package the talk, Salman. So that shouldn't be a problem. So
Dr. John, you still Dr. Bennett, you still stay in Nepal?
Yeah, I'm still in Nepal. Yeah.
With iPad.
Yeah, he hasn't come in the office yet. This is his office. You weren't here, Dr. Kim, right? You weren't here.
Hi, iPad.
Let me. Oh, I don't know what happened there to the other camera. Oh, hold on, my camera fell off here. Hold on. everything's so fragile here.
John, I just spoke to Nicolai. I just woke him up. It's 5 in the morning. So he's just woken up. He will be joining us in next 5 minutes, he tells me. I told him he's the director. He has to be there. Hello.
He's again offline.
John, I pay?
No, I is not there. And John is gone as well, it seems. Kim, you're bad omen to live neurosurgery because since you've come, John is disappearing.
Maybe I think they maybe pay some preparing the live surgery maybe.
He doesn't like to do something, I don't know.
Okay.
We're waiting and waiting. Anyway, so you'll be coming in February?
Next year, February. Can you give the time?
February, it's 15, 16, 17, but it's going to be, it is mainly going to be skull-based, so, and endoscopy. So maybe in endoscopy, you can give endoscopy talks. Because International Neuroendoscopy President Pepe Chenelli is also coming. So I think it would be interesting. And, you can come and give guest lectures. Not a problem. You're most welcome. That would be nice.
Maybe February 15, 16, 17?
Yeah.
Oh, okay. Do you know that time is a big holiday in Korea?
The big holiday, you do it in Karachi.
Okay. Okay.
You want to do a practice run and just do a screen share and see your screen share is okay, and then run few slides?
Yeah, that will be better. There will be no interruption in this.
Okay, I think that maybe now we start.
No, but you just do a practice run and let John come back. If he can come back in a couple of minutes, fine. Otherwise, we'll start.
Okay.
And can you put your camera slightly down so that we can see you instead of the ceiling? We are seeing the roof more than you.
Okay.
Camera down. So are you using a laptop?
Yeah, laptop.
So just adjust this because you're seeing this at the moment. Can you adjust this?
Oh.
Adjust your camera. Yes, that's better. But you got frozen while doing that.
Okay. Oh.
Little bit more. Down a little bit more.
Okay, but I can. How can I?
Oh, you can't see. So maybe, yeah. Is this a Korean laptop which works differently?
What? Wait, I'm now some.
Kim, you're looking like a Buddha. You're looking you from bottom and you're. What's happening here?
Can you give the? How can I share the my slide?
If you go on the left side, go on the left side of the screen. Left side of the screen. No. Go with your. Go on the left side of the screen, and there is a green thing. Go on the left side. Use the cursor to go on the left side of the screen. Use the cursor. Use the mouse. No, don't do. Okay. Use the mouse to go on the. Use the mouse. Use the mouse.
Mouse.
The mouse go on the left side of the screen. Okay, 1 second.
No.
Let me show you. Can you? Let me show you. 1 second. Whoa! What happened there? I was trying to show you, and this is crazy. Okay, so let me just undo this. Can you see my screen? Yes, no? Okay, 1 second.
No.
Can you see my screen? Oh, I don't know. Doing something silly. Let me just.
Okay.
Kim, if you go on the left side of the screen.
Left side of the screen.
No, you don't go. With the mouse.
Left side here.
With the mouse, use the mouse to go on the left side of the screen. Then you will see 4 signs. One is a green sign which says screen share.
Yes, screen share.
Yeah, screen share there.
Now
click this.
You can. Okay, it's okay.
Yeah. Yes, that's fine. That's good.
Yes, that's fine.
That's good.
That's good. That's very good. So go next. Show the next slide. And show the next slide.
It's okay.
It's working. Okay. What you need to do is maybe reduce the size. Go back.
Size.
Yeah, because our pictures are hiding your bottom of the slides. So maybe, once, I don't know how you can do this. Maybe you want to play just like this, without going on to the slideshow. Just play it without being the slideshow, so that we can see the bottom, because on the bottom we see all these people who will be hiding your slides. Do you understand?
No, if I can interrupt, Dr. Salman Sharif, I think you will get one more option at the top of